Hello, I'm Dr. Paul Mandlin, and I'm a radiation oncologist at City of Hope. And today we'll be discussing breast cancer and radiation therapy. So I have nothing to disclose. So the overall goals of today's presentation are we're going to go over the staging of breast cancer, what a typical workup might involve, what the radiation recommendations for breast cancer could potentially involve, be it early stage breast cancer, locally advanced breast cancer, or post-mastectomy treatment. And we'll also go over the delivery of radiation therapy, what to expect, and some of the common side effects. So as a quick background, breast cancer is still the most common cancer diagnosed in females. Prostate is the most in men. And it's the second most common killer in females, when lung cancer still predominates in both males and females. So staging of breast cancer is typically done based upon what's called the T, N, and M system. The T stands for the tumor size or what it involves. N stands for the lymph nodes. How many are there, where are they, and are they involved? And the M stands for metastasis, has it spread any place? And then after we do surgery, you can get a final pathologic stage based upon the clinical stage, which we just went over, T, N, and M. And then the pathologist gives you all these extra results, the grade of the tumor, special staining studies that are done, and we'll go over some of those, receptor status, and then immunohistochemistry and other genetic testing that can be performed. So a typical presentation of a breast cancer patient is either you have a screening mammogram done as part of an annual physical exam, or someone feels a lump in the breast or something in the armpit area or a lymph node in the axilla. So you would go to your primary care physician, they would order imaging, and we would get mammograms. And this is a typical mammogram, right side, left side. This is a view looking straight down from head to foot. We call that a CC view. And then there's a kind of an oblique projection from the middle to the outside, medial, lateral, oblique. And you can see the breast kind of hanging down here. And this is the chest wall muscles. And so in this area, there's kind of a more dense region that we're interested in, that the radiologist wanted to take an extra look at. And in the opposite breast, there are some benign calcifications and even a prior biopsy clip that was benign. So after you get a standard mammogram, which is what you just saw, a screening mammogram, the radiologist or the primary care can request a digital diagnostic mammogram that does extra views with or without an ultrasound. And then depending on the results, you can get an MRI or even go as far as CT scans or PET CT scans. And again, not all of these are required for every case. So this patient went on to get a digital diagnostic mammogram. So here's that same view from medial to lateral. And now there's a biopsy clip already in this particular one, but in the area that they were concerned about, they did a biopsy, and incidentally noted also there was a lymph node up in that armpit area, and they biopsied that as well. This is just another view showing that same area prior to the biopsy being done. So the biopsy was done under ultrasound guidance. So they went in with an ultrasound probe through the skin with gel, and they saw this area that they were interested in. It's darker than the surrounding tissue. It's more dense. And under ultrasound guidance, They stick a needle in and verify that they're in the spot they want, and then they get some tissue out to make a diagnosis. Now in this patient, because we already had a lymph node that was suspicious, she also went on to have a bilateral breast MRI. So here's both breasts. Here's the area that we're interested in. It's a large lump that's brighter than the surrounding tissue, meaning it's taking up the contrast that we give in the vein, so it's enhancing. And here's that lymph node that was up in the armpit area, also brighter than the surrounding tissue, what we call enhancing. Left breast was negative. And again, not everyone needs every single study, but this patient also had a PET CT scan. And what a PET scan is it's basically just radioactive sugar. So anything that's growing or dividing or infected or inflamed is going to show up. So it's sensitive but not specific. So here's that lesion in the right breast with a little biopsy clip in it. And same thing, that same area we just saw on the MRI is also lighting up on the PET scan, and it also contains that clip, meaning that we biopsied the two areas we were interested in. So now the pathology comes back from the pathologist, and there's two broad main categories of breast cancer. There's what's called in situ carcinoma or pre-invasive disease. It's still a breast cancer, so it's a misnomer to call it a pre-cancer. And then there's invasive carcinoma, and we'll go over those two in a little bit more detail. So this pre-invasive or ductal carcinoma in situ is still a cancer, but it's confined to the milk duct system. So the breast is comprised of all these lobules that make milk and all the ducts that go down and end up in the nipple. And so a DCIS or a ductal carcinoma in situ is those cells are still confined within that milk duct system. And a mammogram for a DCIS is slightly more difficult to interpret. That's why we leave it up to the radiologists. You can have normal calcifications in a milk duct, just like you can have calcifications in an artery. But if they become grouped or clustered or abnormal in appearance, that's when the radiologist would consider getting a biopsy. Now, invasive ductal carcinoma is that same cancer, but now it's broken through that milk duct system. And this is more typical of when you would feel a lump because it's coming through the walls of those ducts and can grow and form a little nodule. And again, here's a little bit more obvious mammogram of an invasive ductal carcinoma. It's a larger lesion, not just a bunch of little spiculated calcifications in a duct. So the biopsy comes back and we want to look at a whole bunch of different options of where that cancer is coming from, what the different grades and stages are. So they're going to give you a histology. They're going to give you an overall grade, 1, 2, or 3. They're going to give you receptor status, meaning does it respond to the female hormones, estrogen, progesterone, and other special tests. They can do immunohistochemistry on it depending on the type of tumor it is. And then there's all these special studies that we can now order to help individualize treatment for people. And those include things like Oncotype, MammaPrint, EndoPredict, and Foundation 1 testing. And those all help us to determine what type of treatment does a patient need after surgery. And that can include chemo and radiation therapy and hormonal therapy versus other immunotherapies and adjuvant treatments. So the grade, as we alluded to, is just low, intermediate, or high. So it's going to give you a grade 1, 2, or 3. And it's the same for both invasive carcinomas and ductal carcinomas in situ. So the pathologist looks under the microscope and gives a grade. And we won't go over all of these different things, but there's multiple different types of cells that both a DCIS or an invasive ductal carcinoma can be made out of. So also the pathologist is going to give you those receptor studies. So does the tumor respond to the female hormones? And the three most common are estrogen, progesterone, and then a special test called the HER test or the HER2 test. And that tells us would the tumor respond to a drug called Herceptin. So most common breast cancers are estrogen and progesterone positive, meaning they respond to the female hormones, and Herceptin negative. And then you can have any multiple combination of all of those, all the way up to triple negative, where the tumor doesn't respond to any of those. So now that we have a biopsy proving cancer, and we know approximately the size based upon imaging, we can come up with a clinical stage. So that's just broken down into T for tumor size. So T1s are anything below 2 centimeters. And it's just broken down into A, B, and C. 1 to 5 millimeters is a T1A. 5 millimeters to 10 millimeters or 1 centimeter is a T1B. And then 1 centimeter to 2 centimeters is a T1C. A T2 tumor is between 2 and 5 centimeters. And then it goes up from there. And T4 can involve the skin or the chest wall or have inflammatory features. And that's where the skin is involved with redness and irritation. We do the same thing with lymph nodes. So now we're on the N part of that T, N, and M. So clinically, we're just seeing, is there a lymph node that's palpable? Is it mobile? Can you move it around, or is it fixed? And how many do you think there are, and what's the location? Is it just limited to the armpit area, or are there lymph nodes up and surrounding the collarbone or the clavicle? And so staging has become much more complex. And the reason I'm going over staging is it's difficult now to compare a stage 1 to a stage 1. So in the old days, someone could say, you know, oh, my breast cancer was stage 1 and mine was a stage 2. And that meant very different things. Now, a stage 1 isn't a stage 1 isn't a stage 1 anymore. So you can have a stage 1, which is just a T1 tumor, very small, with no lymph nodes involved. Or you can have, you know, a stage 2 tumor that is a little bit larger, like a T3, but still doesn't have any lymph nodes. So again, the only reason is everything is individualized, and so staging is much more complex. And someone with a stage 1 tumor might be treated very differently if it's stage 1A versus stage 1B. So now that we have a diagnosis, typical is to take the tumor out. And there's two main types of breast surgery. That's either breast conservation or a lumpectomy, meaning you just take the tumor out. And then there's mastectomy, where you take the whole breast off. And at the same time, depending on how those initial images and staging studies turned out, you also want to address the lymph nodes. And so a sentinel lymph node biopsies, you just sample lymph nodes that are draining that area of the tumor in the breast, or there's an axillary dissection where you take out more lymph nodes throughout the armpit area. So once the tumor is out, now you can get a final pathologic stage based upon both the surgical specimen, so the final size that the pathologist measures, and how many lymph nodes there are. So now we can count them and we can see all these different prognostic features, including tumor size, lymph nodes, grade, and all those receptor studies. And again, it's broken down into overall stages from 0 for ductal carcinoma in situ or DCIS, all the way up to stage 3 and 4 for invasive cancers, based upon all these different factors. And here's the same slide, just going up in tumor size, so T2 and T3, and T3 with more lymph nodes positive. And again, just an overall discussion of how we get to that final overall stage, which again determines treatment. And also on the pathologic specimen, they're going to order usually one of those specialized tests. Oncotype is one of the more common ones, and that helps the medical oncologist to determine what would be the benefit from systemic chemotherapy, where it used to be any tumor over a centimeter or any lymph node positive, pretty much anyone would be recommended for chemo. And now with these new scores, some people may be recommended for chemo that wouldn't have been in the past, and some people might not need chemotherapy. So chemotherapy, medical oncology handles this, but there's different ways of giving it. So there's chemotherapy first before surgery. We call that neoadjuvant, meaning you want to try and shrink the tumor to make the surgery easier and potentially clear some of the tumor from any lymph nodes that are involved. Then there's standard chemotherapy after surgery. And then after surgery and chemotherapy and potentially radiation, there's adjuvant treatment, or treatment that's after the definitive surgery, and that can be hormones, depending on how those receptor studies turn out. Do we want to block the female hormones if the tumor responded to those hormones? And then there's other targeted agents, again, depending on those special staining studies, like the HER test. So would you give Herceptin, depending on what the actual tumor responds to? So individualized care. So from the radiation standpoint, there's two main categories of radiation. There's radiation we give after the lumpectomy, and within that, there's also partial breast radiation, meaning you just treat the surgical bed. There's post-mastectomy radiation, so after you take the breast off, you want to treat that area of the chest wall. And then the lymph nodes. Do you treat just the lymph nodes in the armpit area, or do you treat more extensively, again, based upon imaging and the final pathology results and how many lymph nodes were initially positive? And we can also give radiation for palliation of metastatic disease, either to something like a bone or other organs. So the goals of breast cancer radiation therapy are: we want to improve local control, meaning we don't want the tumor to come back in the breast. We want to decrease the chance of the tumor recurring locally, both in the breast or chest wall area or in the lymph nodes. And in certain cases, we also improve overall survival, meaning that by decreasing these chances of tumor coming back, people live longer. So, typical of radiation therapy in the modern era is everything is CT planned. So each treatment is customized to the individual. So a typical visit would be to come to the radiation department, be put in the treatment position with both arms up over the head, because we don't want to treat through the arm to get to the breast area. And then we do a CT scan, and that image gets put into the treatment planning computer, and we can actually design the radiation on the actual person, so individualized. This is a left-sided breast cancer. We mark the scar where the surgery was with a wire, and we can draw that in on the computer. And then since it's left-sided, we want to avoid the underlying heart. And so the beams don't come in from the front, from the back, they come in at an angle, kind of skimming through the chest wall and treating the whole breast region, including where the tumor was removed. So here's that same picture now in the planning computer. So we're taking one slice looking up from the feet. This is the heart. Here's the breast, and here's where they took the tumor out. And you can see the radiation comes in from right to left, and then from left to right, kind of skimming through the breast, avoiding the heart, and intentionally treating a tiny corner of the lung, because as the chest wall moves when you breathe, we don't want to be missing anything. And then once the whole breast has been treated, you want to kind of focus in just on where that tumor was taken out. And depending on where this cavity is located, how deep it is, and what structures are in our way, you can do that either, again, with two opposing fields that come in and just focus on that region, again, avoiding the heart and lung. And in other cases, we can do that with a different type of radiation. And I'll show an example of that in a few slides. So this is a breast cancer of the opposite side. Now this is a right-sided breast cancer. Same thing. We mark the scar where the surgery was done, do the CT scan, and now the beams are coming in from the opposite orientation. So from left to right and from right to left. Again, just skimming through the chest wall area, so we only treat the breast tissue. Here again is that same plan. This was an early stage breast cancer. She had a history of prior breast augmentation. And so breast implants and radiation doesn't really affect the outcome. It doesn't affect the way that the radiation works. This is just either a bag of water or silicone. So it doesn't really affect the dose of radiation. And again, we draw in that tumor bed, and this one still had a marker clip inside. And you can see we can avoid the opposite breast and just skim that little corner of the lung, because as again, the chest wall is moving and you're breathing, we don't want to miss any of the breast tissue. And so with this case, since the tumor was very superficial and there's this implant on top of the chest wall, we were able to treat the tumor bed with a very localized type of radiation, just to treat the tumor bed and not have the radiation penetrate very deep at all. And here's that same field just right around where the surgical scar was. This is a slightly more locally advanced breast cancer. So this is again a right-sided breast cancer, but there were lymph nodes positive. You can see there's a scar marker in the axilla. So we're going to treat the whole breast area where the breast used to be. And we're also going to treat the lymph nodes above and below the collarbone, because a lot of these lymph nodes in the armpit area were positive. So we want to kind of be the cleanup crew and treat that whole area with radiation. So here's that same plan. She had an implant reconstruction immediately after her mastectomy. So again, we want to treat that whole chest wall area. And then higher up, right up by that collarbone, you want to also treat the lymph node regions that are draining the whole area of the breast or chest wall. So radiation therapy side effects are broken down into two broad categories: early versus late. So early side effects can be a skin reaction. That's the one that people most commonly associate with radiation, and it's a sunburn type of a skin reaction. It doesn't matter how you burn in the sun. I've seen people really fair-skinned, or people that say they have very sensitive skin. I've seen them fly right through treatment. I've also seen people with very dark or olive skin get a significant skin reaction, and that can be anywhere from redness and dryness to increased sensitivity or discomfort, just like a sunburn. And it can even be blistering or peeling, and with the dryness you can also get a little bit of itching. Sometimes people can get a little bit of edema or swelling in the breast area, or the breast can feel heavier on that side. And during and slightly after treatment, some people can also get a little bit of fatigue. The best way I have to describe why that happens is it's kind of like you're getting over a cold, but you're not sick. So the body is just repairing that little bit of damage that the radiation does every day, which is why we have to break it up into several small pieces over several weeks. Just like you can't take a course of antibiotics all in one day, you have to break it up, over 7 to 10 days. So then late side effects of radiation is after that sunburn goes away, there can be pigmentary changes of the skin. There can be some tanning, and that normally fades over the next 6 months to a year. Some people it's much slower, and some people it's much faster. And there can be, in rare cases, some lighter or darker spots which are permanent. There can be a little bit of scarring, just like after surgery. So doing radiation is like doing surgery without a knife. So there can be scar tissue inside that area, but the breast isn't going to be rock, woody, hard, but it can be slightly more firm on that side. Lymphedema is mainly a postoperative complication when you have to dissect the lymph nodes in the armpit area, and that's described as swelling or puffiness in the arm or hand. And if you have to do lymph node surgery with chemotherapy and radiation therapy, that's when this chance goes up, and it's still not as significant as it used to be. Current data shows it's maybe about 25 to 30% chance, again, depending on how many lymph nodes were removed. Some of the other late side effects of radiation, there can be local hair loss. Again, we're not like chemotherapy, so we're the local guys only. So if it's not in the area that we're treating, it's not going to happen. That's what I like to say. So there's not going to be hair loss on the head unless we're treating in the head or brain area. And then very rare complications. There can be rib fractures, heart problems, lung problems, nerve problems, or even the development of a secondary cancer. And again, these are very rare with the modern computer-controlled radiation, where we can really focus in on what we want to treat and avoid all these critical structures. So here's some real-life examples. This is a lady that had the early stage breast cancer with a history of prior breast augmentation. So this is the day of her CT scan, where we kind of mark that scar right along the areola. We kind of put some markers on here for the general borders that we're going to be treating. And this is the last day of treatment. So a little bit of dry peeling up in the armpit area, and you can see the nice square of tanning. And for this particular lady, she just finished, so I do not have a follow-up picture. But here is a chest wall case. So this is a left-sided cancer. And this lady stated she had very sensitive skin, and she is correct. She actually had, where she had her port put in for chemotherapy, she had a significant reaction to the skin glue. And you can even see right around her scar and then the scar on the armpit, she had a little bit of a reaction. So she had very sensitive skin, admittedly. And then 1 month after treatment, here's her skin. So if you can imagine, it probably looked a little bit like the previous slide. And now there's only a little bit of tanning kind of left here in the armpit. But basically her skin looked great 4 weeks after treatment. Here's another chest wall treatment for a right-sided breast cancer. So again, we mark the scar at the time of the CT scan. So this is before any radiation was given. Kind of mark our general borders with little sticky wires. And she completed treatment. And 1 month later, you can just barely see the square of tanning that's continuing to fade after the radiation treatment. And finally, here's a reconstructed breast for a left-sided breast cancer. This is, again, CT scan before any radiation was given. Mark the scar, mark our general borders. And now 10 months after radiation, the skin is basically completely healed and back to normal. This is a little bit of a weird shadow from the lighting in the room, but all the tanning has almost completely resolved. So with that, I'll conclude today's talk, and thank you for your attention.